Hello students, myself Professor Dr. Jayachandran from the Department of Periodontology and Implantology, BMS Dental College. Today I am going to talk about the concepts and current trends in Osseo Integration, which is an important part of dental implantology. As any other word from the medical field, the Osseo Integration derives from the Greek word. The osteon means bone and integrate means to make whole. So anything that binds well with the bone, it is Osseo Integration. When I talk about Osseo Integration and implantology, a person by name Dr. Ingvar Brainymock cannot be forgotten. The person is known as the father of modern implantology, and he is a Swiss physician. And how a physician turned to be a father in implant dentistry, the story will be revealing soon. Coming to the definition, the Brainymock defined it as a direct contact between the bone and the metallic implant without interposed soft tissue layer. Later, he modified the definition as structurally oriented definition, such as direct, structural and functional connection between the ordered living bone and the surface of a load-carrying implants. So coming to the history of how the evolution began, this is a rabbit and tortoise story. First started with the rabbit. As I previously mentioned, the Brainymock is a Swiss physician. He was doing a research on bone hematology, and he was using an optical chamber made out of titanium, and he has inserted it in the fibular bone of a rabbit. And by doing so, he is doing the research on the blood circulation in the rabbit body. And after this research completion, when you try to remove the optical chamber, because that time it was costly, it is custom made, and also the funding was not available like now. While removing the optical chamber, by fracturing the fibular bone, there is a spark in his mind how a foreign body was not rejected in any system, and it is firmly integrated in the bone, and the biocompatibility of the material was immensely witnessed. So that paved the way for the Osseo Integration. After his invention, he tried in various animal studies like a beagle dog, and he created a mandibular defect in that, and he used a titanium screws and fixtures to fuse the defect. After the successful animal study, he has got into the first human trial with a Kostal Larsen from Gothenburg, Sweden. He was the first recipient of Osseo integrated dental implants. He is a natural cleft palate patient who is completely edentulous. So he used the implant fixture. It was called by then, it was not dental implant that time. He used a titanium implant fixture for rehabilitated him for a better function. So this is an iconic picture where you can see a Brainymock alongside his first patient, that is Kostal Larsen. It is when he was around 64 years. It is about 40 years of successful Osseo integration by then. Now we are in the 50th year of Osseo Integration. So the Osseo Integration is more successful and a trusted procedure in dental implant. And the story never ended there. After his initial clinical trial in 1960s, he started various processes like auricular processes, nasal processes and ocular processes, and then lead to the orthopedic procedure. So as we cut short here, the invention started in 1950s with the accidental discovery. Then the tissue integrated process, experimental studies was done in beagle dogs. Then in 1965, as we seen, Kostal Larsen was the first clinical trial. He was rehabilitated with the implant fixture. Then it has passed on with maxillofacial audiology, hand surgery and orthopedics. So the story never ended here. Here, coming to the tortoise story. It took 30 years for Brainymock to convince his medical fraternity about the Osseo Integration and how essential it is for rehabilitating in any condition, like not only in dental but also in medical profession. So the real story is, as Osseo Integration takes time, for any invention you need to have a patience so that it will be taken by any fraternity. So that's the end of story, and we are in the 55 years of Osseo Integration, a successful trusted ally. So how it works? So behind the scenes, a biological process of implant Osseo Integration, we will see how the healing takes place during Osseo Integration. The key players here is the platelet, which is the main incredible role in clot formation. The endothelial cells, which plays an important role in selective permeability so that the inflammatory cells can pass on to the inflamed site. Then comes to the PMN, that is acute inflammatory cells, which plays a major role in acute inflammation. Coming to the stages in initial healing, it is like in stages in initial healing. Like the healing is very normal compared to the any other injury. When you are doing osteotomy, there will be a traumatized capillaries and blood vessels, and there will be extravasation of blood in that site. And these release of blood cells will also release like protein, plasma proteins. These plasma protein will coat the implant surface, that is titanium implant surface, and there will be release of vasoactive amines. These vasoactive amines like serotonin, these things will increase the vasodilatation, and there will be more blood flow. And these blood flow is important to cause have a more inflammatory cells to that area. Then goes the fibrin clot formation. This is the initial clot formation. As I said, the key player is a platelet. Once the platelet aggregate, the fibrin clot formation will be seen alongside the implant surface. Then there will be a debridement of macrophages. This is an important scavenging action that cleans the site of injury. And by doing it, it can phagocytize the dead cells and debris and also the microorganism there. So the area where the implant is placed will be sterile. Then comes the angiogenesis and osteoprogenitor cell migration. When come to angiogenesis, this is the formation of new cells and new capillaries there, and that will bring a lot of oxygen to that area. So the site will have an excellent prognosis in form of osteoprogenitor cell migration, which will form a new layer of osteoid bone, the immature bone formation over the implant surface. Then there will be organization and replacement of hematoma by granulation tissue. This granulation tissue will be having new capillaries and connective tissues, collagen, and that will help in healing. Then the replacement of granulation tissue by the immature woven bone. This woven bone, the immature bone, will be formed over the implant surface by the osteoblast cells, and later the woven bone will be replaced by the lamellar bone. The difference between woven bone is a disorganized bone, which is weaker, and the lamellar bone, which will form later, will be little more organized. And when the secondary remodeling of the woven bone will take place, the mineralization will also take place, and the bone will be more stronger around the implant. So it will take a time-consuming procedure. So when you are talking about Osseo integration, as in within seconds after the osteotomy preparation, the serum protein attaches to the implant surface. Then within 3 days, the mesenchymal cells attach and proliferate. And in 6 days, the osteoid is produced over the implant surface. And after 2 weeks, the matrix calcification will take place. And 3 weeks, bone remodeling will start to occur. But the mineralization and calcification will take place at around 6 months. So the loading of implant should be delayed, and so that the healing around the implant surface will be complete. Coming to the key factors, what are the key factors that will play a role in osseo integration? The first one is the material involved. Basically, as we started with the titanium fixture by Brainy-Mock, the titanium is, even now it is used because it is excellent biocompatible material and it shows excellent results. And now the zirconia is taking a little role. There are a lot of research going on zirconia material. Basically, for those people who are sensitive to titanium alloy, and also for a aesthetic consideration, zirconia was considered. But the research is in the premature level. So right now the titanium is the best material for excellent osseo integration. The next one is the surface of the implant surface. Initially when the implant was started, they had a smooth surface very similar to the root surface. But later, with so much of researches, they found the rougher, the better osseo integration. They have roughed the implant surface by doing acid etching, they do the blasting procedure, and they have done a plasma spray, and a lot of surface characterization was done to make the implant surface rougher. That will aid in a better osseo integration. Then comes the implant tomography. That is, the tomography changes will be from a micro level and also macro level. The micro level tomography changes will be in the form of a porosity. They created porosity on the implant surface, very similar to the root surface. And then they created macro topography in the form of the design changes, the threads, the pitches, and maybe the platform switching. Everything was done for the macro and micro level for enhancing better osseo integration. Then comes the implant stability. When you talk about implant stability, it is of two forms, primary stability, which is a mechanically oriented, and secondary stability is a biological one. When it is a primary stability, it is achieved while placing an implant, at the time of implant placement. And there, when you're doing osteotomy, the osteotomy will be done a size below to the implant placement, so that you will get the initial stability when you're placing the implant. and it is driven by the old bone which is present that time during the implant placement. When it comes to secondary stability, it's biological. That is, after healing, when the new bone formation forms around the implant, the secondary stability will start. So this graph will clearly depict the difference between the primary and secondary. As I said, primary stability is during the implant placement will be higher, at the initial level, and later at the gradually during the weeks and months, the initial stability will start to dip. And the secondary stability will start to increase during the healing period from the 5th week to the final 3 months to 6 months. The secondary stability, that the biological stability, will increase. So as you see here, there will be a stability dip, that is the intersection between the primary and the secondary. This stability dip will be seen around the 6th and 7th week of healing. So when you are planning for loading an implant placement, you should wait for the secondary stability to achieve its peak, that is 3 to 4 months. It is ideal for getting go for a loading, that because you will get excellent osseointegration. Coming to the bone quality, the osseointegration will also depends upon the bone quality which is available in the implant site. The bone quality, it is of type 1 to type 4. The type 1 is a homogeneous compact bone. The type 2 is a thick layer of cortical bone, surrounds a core of dense trabecular bone. And quality 3 is a thin layer of cortical bone with more of a trabecular bone. And quality 4 is a very thin layer of cortical bone with the low density trabecular pad. Here, the poor quality is quality 4 and higher quality is quality 1. But when you are talking about the better quality for placing an implant, it is quality 2, because we don't want a complete compact bone. We need some amount of cancellous bone, because as I said, for healing of around the dental implant, for a better osseointegration, we need a blood clot and the progenitor cells to come over there. So we need some amount of trabecular bone for that. There will be better osseointegration. So the quality 2 is the best, and the quality 1 and quality 2 bone will be mostly seen in the mandibular area, and the quality 3 and quality 4 will be seen in the maxillary area. Later we will see, even in a quality 4, we can get a excellent osseointegration by there is a change in techniques, and with the use of regenerative material we can achieve. That will cover in the next lecture. The next one is the defect. That basically a classical implant, if you want to place an ideal site, it will be around a millimeter, 1 millimeter of bone surrounding the implant surface. It is ideal. If it is more, it is more better. But if it is less than that, it will come under one of the classification by the CYBIRD in 1983. The class 1 defect is a horizontal buccolingual defect, and class 2 is a vertical, that is apicocoronal defect, and class 3 is a combination of a buccolingual and apicocoronal defect. When you are placing an implant in this defect site, the osseointegration will depends upon the type of regenerative material you are planning to use. And the biological healing, that is the secondary stability, will take time, so that because of regenerative material which you are going to plan around the implant defect site for a better osseointegration. So ideal site, the osseointegration will be trusted, and the healing period will be 3 months to 4 months. When you are doing a defected site, you have to wait for the biological healing, and you should give more time for a better osseointegration. Then coming to the key factors that plays a role in osseointegration, it's just already covered here. The biocompatibility depends upon the material which we used, that we know the titanium is the best one. The implant design, the change in topography, micro and macro level, and the implant surface treatment, and the loading consideration and the prosthetic consideration is very important factor, when to load and how much time we need to give. So all these things is a key factor for osseointegration, which we already covered. Then the most common question everybody will have, what is the fibrointegration and what is osseointegration? As we said, the osseointegration, by the definition, it is the functional contact between the implant surface and the bone. There should not be any interface between, any soft tissue interface in between. Whereas fibrous integration is not a direct reunion of a bone surface to the implant surface. There will be an intervening connective tissue. So this is marked as a failure. We don't need the connective tissue in between the implant and titanium. So a fibrous integration will be considered as a failure. Osseointegration is very much needed if you want the implant to be success. Then coming to the bone formation, there is a mechanism involved in the endo-osseous integration. It will be a distant osteogenesis or a contact osteogenesis. What is the concept behind these two? Basically, when you are placing an implant, as we previously mentioned during the healing phase, the plasma protein which coats the implant surface, and this will be positively charged. And even then, the implant which we are right now using is highly positively charged. It is plasma sprayed and all the bioactive substances is coated over there. So this will attract the cells to attach over the implant surface. So the bone formation will form from the titanium implant surface to the defect site. So the contact osteogenesis is, as we can see here, the bone formation starts from the implant surface towards the defect site. So this is the one which is applied in the implant dentistry. So what is distant osteogenesis? The distant osteogenesis concept is the bone formation not start from the implanted site, it is from the surrounding defect site the bone formation starts and it will reach the implanted surface. This concept will be mostly applied in the case of distraction osteogenesis, where we are increasing the vertical height of the ridge defect. There we can see a distant osteogenesis, or where we are going for a fractured a large defect where we are planning for a reunion. Those conditions we go for a distant osteogenesis. But as far as implantology is concerned, contact osteogenesis is the concept. So there are a lot of other questions which will creep in your mind, some food for thought. What is the concept behind basal implants? So whether Osseo integration is a concept in basal implant or any other concept is there for fixing, like rehabilitating the teeth, or what is the concept behind osteodensification? Like as we seen the quality of bone when it is grade 4 or grade 3, the osteodensification will give an excellent result. So what is the concept? What is the technique behind osteodensification? And as we said in the ridge defect, or when you are going osteodensification, what is the protocol we need to follow as far as a regenerative material is concerned? So all these things will be covered in the future classes. Thank you for patient listening, and it's me, Professor Dr. Jayachandran, signing off until then.